wow, we have so many
Yeah, I think
attendants today.
they are now entering. Some of our students trying to entering now. So
Yeah, and we have nine people from Silpakorn University,
oh yeah.
academic staff, and one of my students.
Okay, thank you so much for your time and also your student as well. So, Dr. Daisy, is it possible to start now?
Yes, sure.
Okay, so thank you very much. So, okay, we are going to start now. So, okay. So good morning, everyone, and very warm welcomes. I am Lalu, and I'm thrilled to be your moderator for today's webinars for this morning webinars entitled "The Anemia of Chronic Kidney Disease in 2025." Cutting-edge updates and evolving management strategies. We have our audiences to this from our teachers and also from our postgraduate students. And we appreciate you all taking the time to join us on this morning's webinars. So today we are focusing on I think it's actionable insight, the key updates and strategies that you can use immediately in managing anemia of the chronic kidney disease. We encourage you to actively participate by asking questions later on after discussion sessions. We have an exciting agenda, including our guest speakers. Here is Assistant Professor Dr. Daraporn Rungprai, or her English name is Dr. Daisy. As speakers who will share to every single of us about her knowledge and experience on management of CKD. All the participants encouraged to active involvement is very crucial. So don't hesitate to engage with our speakers and each other here. So let's get ready for informative and practical sessions. And I'm looking forward to great discussions with all of you. And before we start, I think let me introduce our guest speakers for today's webinars. So I'm sharing first. Okay. Let me introduce our guest speakers for today's webinar. Okay, so our speakers for today's event is Assistant Professor Dr. Daraporn Rungprai. She is the academic staff and Assistant Dean of Faculty of Pharmacy, Silpakorn University in Nakhon Pathom, Thailand. She graduated from Silpakorn University with bachelor degree in clinical pharmacy, and she obtained board certified pharmacotherapy or BCP,
Lalu Muhammad
in
Irham
nephrology pharmacotherapy from College of Pharmacotherapy of Thailand. She was a visiting scholar in nephrology pharmacotherapy at the College of Pharmacy and the University of Illinois Medical Center, Chicago, United States. Dr. Daisy or Dr. Rungprai received the certificate of Fellow of Papa College of Pharmacy or FECP, specialized in pharmaceutical care from the Federation of Asian Pharmaceutical Associations in 2015. She also obtained the certificate of treatable L teachers of ESPN's lifelong learning programs on clinical nutrition and metabolism from the European Society for Clinical Nutrition and Metabolism in 2021. Dr. Rungprai currently serves on a number of boards, including the Thai Renal Pharmacist Groups and the Society of Parenteral and Enteral Nutrition of Thailand. So thank you, Dr. Daisy, for your time. So I think we are waiting for your sharings for this morning webinar. So the time for you.
Thank you, Dr. Lalu, for introducing me. And I'm so thrilled and happy to see you all today. So thank you to the Faculty of Pharmacy, University Ahmad Dahlan, for having me today. As under our academic MOU, right, we have a good friendship, good academic relationship, and we are good university partners. So thank you very much. And today, I will talk about the update data of the anemia management in CKD. So let me share my slide. Okay, you guys see my slide clearly? and hear me clearly, right? Okay, so I'm gonna start. Okay, so I have to say that currently in the field of nephrology pharmacotherapy, we have so many issues that are like currently updating. But for the upcoming update that is very interesting and I'm sorry, and it will be soon launched. New clinical practice guideline is anemia management of anemia of CKD in 2025. So today we're gonna talk about the anemia management in the population of CKD patients. So my talk outline will be the first one. I'm gonna give you a basic review about the anemia in CKD. So we're going to talk about anemia definition and diagnosis and mechanism of anemia in CKD, or we call it renal anemia. And I want to share you about the idea in the real clinical practice about when and how we can treat anemia in CKD patient. And the important issue that we're gonna talk a lot more today. So I want to share you about the update for the upcoming clinical practice guideline uh, for anemia management in CKD patients in 2025. And we're gonna go to the conclusion. Okay, for the first one, before we talk about the update data, we should have, like the basic understanding about the basic knowledge of anemia in CKD. So basically, anemia is defined as a reduction in one or more of the major red blood cell measurements. It concludes hemoglobin, hematocrit, or red blood cell count. So the current guideline that we use to manage our patient with anemia of CKD is KDIGO 2012. So if anyone in the field of nephrology, you're gonna know or hear about the KDIGO guideline. So this is the international guideline that we use worldwide to manage and taking care of the CKD patients. So KDIGO launched many guidelines to taking care of the complication in CKD patient. So anemia is one of the important complication in CKD that we need to manage. So currently, we still use KDIGO 2012 clinical practice guideline for anemia in CKD. So basically, I'm gonna talk about KDIGO 2012 guideline first, and then we're gonna go through something new in KDIGO 2025 guideline for anemia of CKD. Okay, for the diagnostic criteria to diagnose anemia in adult and children aged over 15 years old with CKD. For males, if the patient has hemoglobin concentration below 12 grams per deciliter, they are considered as anemia for males. So for females, if the patient has hemoglobin concentration below 12 grams per deciliter, they are considered as they have anemia. So this is the important cutoff to know that if our patient has anemia or not. So before going to the management of anemia in CKD, we need to know just a little about the mechanism of anemia in the patient with CKD. So we all know that one important function of the kidney is producing the hormone that help to produce the natural red blood cell, right? So that hormone we call erythropoietin. So in normal kidney, there are many types of cells. So if we, like classifying the type of the cell in the kidney, we can classify it into two types related to the erythropoietin producing. So we have non-erythropoietin producing interstitial cells. So non-erythropoietin producing interstitial cells, and we have erythropoietin producing cells, or we call it EPC. So these cells can produce erythropoietin. So erythropoietin helps in the process of red blood cell production and differentiation of red blood cell into mature red blood cell to help the body with contain oxygen to many organs in our body, right? So, but in the patient with chronic kidney disease, there's going to be the differentiation of myofibroblasts. So that's me the collagen and myofibroblasts, and reducing in the number of erythropoietin producing cells. So that means the kidney can producing less erythropoietin. So if the erythropoietin is reduced, the red blood cell production gonna decrease too. But we still have like 10% erythropoietin producing from liver, but 90% of erythropoietin produced from kidney. So the kidney is major organ for erythropoietin production. So if the kidney is shut down, the kidney are shut down, it's not mean like the patient body lack of EPO. No, we still have like 10% EPO producing from the liver, but the major organ fails. So they have just only little EPO to work at the agent that helps to produce red blood cells, so the patient can have anemia. So if the patient has chronic kidney disease, the patient gonna have the inflammatory cytokines level increase in the body. And inflammatory cytokine that increase in the patient with CKD can inhibit erythropoietin production too. And inflammatory cytokines can inhibit the production of red blood cell, or we call it erythropoiesis process, right? It's reducing erythropoiesis. So the number of red blood cells is decreased. So in chronic kidney disease patient, if the renal shutdown, the metabolic waste product is increased in the body. So we call this situation as a patient has uremic toxin in that body. So the uremic toxin can inhibit the erythropoiesis also. And inflammatory cytokine can increase or stimulate the release of the protein named hepcidin. Hepcidin will inhibit the absorption of iron. So iron is the important substance for red blood cell production. So when the body needs to produce red blood cell, it should use iron and erythropoietin together, and it can produce red cell. So both iron and erythropoietin is very important. So in the patient with CKD, erythropoietin is reduced. And in the body of the patient with CKD with higher level of inflammatory cytokine, hepcidin is increased. And it can inhibit iron absorption and iron transportation to use in erythropoietic process. So it can cause anemia in the patient with CKD. So for the conclusion, in the normal kidney patient, they're gonna have normal erythropoietin level, and they will have normal number of red blood cells in their body in normal oxygen, because red blood cell can carry oxygen into another organs in the body and can give the oxygen supply. But in the patient with damaged kidney or the patient with CKD, as I mentioned before, so the erythropoietin is reduced. So mostly 90% of erythropoietin is reduced. So it's reduced in number of red blood cell and reduced oxygen. So basically, the picture of anemia of CKD will be normochromic, normocytic anemia. But there are some additional factors of anemia in patients with CKD. So it's very important that we need to evaluate if our patient has any additional factors of anemia in CKD, because we need to manage these factors together with giving exogenous erythropoietin to our patient. So I'm going to talk a little about additional factors of anemia in CKD that we need to find out in our patient. So some CKD patients, they can eat just a little. They decrease in appetite. So some patients cannot eat a lot like previously if they don't have CKD. And they're going to have like vitamin deficiency and also iron deficiency. As I mentioned before, that iron is very important substance that we need to use in the red blood cell production. So if the patient has iron deficiency, it can cause anemia in CKD worsening. So if the patient has iron deficiency, we need to give the patient iron supplementation. And if the patient has acute or chronic inflammatory condition, the production of red blood cell is reduced. And in the patient with CKD, they're going to have shortened red blood cell survival. So in normal population, just the red blood cell survival is around like 20 days, 120 days. But in the patient with CKD, the red blood cell survival could be reduced to like 60 to 90 days, only 60 to 90 days. So some patients with, like less appetite and they cannot eat a lot, they're gonna have their folate or vitamin B9 or vitamin B12 deficiency. So folate and vitamin B12 is the cofactor in the red blood cell production process. And the patient with severe hyperparathyroidism, if the patient had intact parathyroid hormone level in the body very high, so like they have very high intact parathyroid hormone in that body, it's gonna cause bone marrow fibrosis, and the red blood cell cannot produce really well. So some patients, some CKD patients, they have hyperphosphatemia, and they can have like aluminum hydroxide for phosphate binder. So if they have long-term aluminum hydroxide as phosphate binder, they can have aluminum toxicity. So one symptom of aluminum toxicity is anemia. So this is very important that we need to avoid giving aluminum as phosphate binder for CKD patient for a long time. We can use this only short-term therapy, like not more than 4 weeks. And if the patient has hypothyroidism, this hypothyroidism can reduce iron absorption. So it interfere with iron absorption. So if the iron absorption is not good, the level of iron that the body used to produce red blood cell is really low. So that can cause anemia and CKD worsening. And if the patient has other, like hemoglobinopathies or thalassemia or hematologic disorders, so it can cause the worsening of anemia in CKD. So we need to manage in the specific treatment of hemoglobinopathies or thalassemia. We need to consult hematologists for additional treatment to the proper management of this cause. So, like I said before, poor nutrition status, like the patient with anorexia or intercurrent illness, or the patient with CKD who have like very intense dietary restriction, gonna have poor nutritional status, and the red blood cell cannot produce well in this patient. So why we need to concern or we need to treatment the patient with anemia? So as I told you that chronic kidney disease patient, if the renal shut down, the patient had anemia, so the oxygen demand is the same, but oxygen supply is less, right? It's lower than before. So the heart need to work a lot more. So it can cause like left ventricular hypertrophy, and it can cause congestive heart failure in this group of patients. So that's why we need to manage anemia in chronic kidney disease patients to prevent left ventricular hypertrophy and reduce the chance of the patient to have like heart failure. So this is the concept of anemia in CKD treatment. So the first one that we need to do is to address on correctable causes that can cause anemia in the patient with CKD. Like if the patient has continuing blood loss, or the patient has chronic blood loss or not. Like some patient has chronic GI ulcer or duodenal ulcer. If we don't correct that cause and we give the patient like iron supplementation, give exogenous erythropoietin to the patient, we cannot correct the real cause of the anemia, okay? So we cannot increase hemoglobin of the patient. So that's why we need to address on correctable cause and manage that correctable cause. Like if one patient has hemorrhoid, so we need to tell the patient to go to see the doctor and already finish with the hemorrhoid treatment, and then we need to investigate that if the patient has deficiency of iron, phosphate, or vitamin B12 or not. If the patient has iron deficiency, folate deficiency, or vitamin B12 deficiency, we need to give the supplementation, the vitamin supplementation, the iron supplementation to the patients before we start the exogenous erythropoietin, okay? And also other additional factors that I mentioned before that we need to assess and investigate in our patient. So we need to talk with the team. We pharmacists cannot, taking care of the patient alone. We need to talk with the doctor. We need to consult them. We need to work with the nurse. So to investigate the patient. And we're gonna have the information, much more information for the patient treatment. And if we have already correct all the correctable cause that can cause anemia in the patient, we need to investigate if the patient has iron deficiency or not. Because iron is the main substance and very important substance to produce red blood cell. So if the patient has iron deficiency, we need to give the patient's iron therapy or iron supplementation. And then if the patient has, sufficient of iron, we can start erythropoiesis stimulating agent, or we call it in short ESA. in the patient with CKD, as I told you, that the endogenous erythropoietin is decreased because kidney cannot work really well, and is decreased in the erythropoietin producing cell, right? So we need to give the patient exogenous erythropoietin. So currently, we have so many kinds of exogenous erythropoietin, so we call it erythropoiesis stimulating agent, or ESA. We're going to talk a lot more about ESA later. So the management of anemia in CKD, the important issue, one important issue that anemia therapy in patients with CKD requires effective use of iron agent, as I told you before. So we need to know the iron status of the patient, right? How do we know the iron status of the patient? We need to investigate from the laboratory test, okay? So that's why we need to talk with the doctor. We need to talk with the team that we need to, do the test for iron status. So the testing of iron status include serum ferritin, serum iron, the IBC, or total iron binding capacity, and we can calculate the percentage of transferrin saturation, or we call it TSAT. So the goal of iron therapies are to avoid storage iron depletion. So we don't want iron depletion in our patients. So we need to give the iron therapy to the patient that we found that they have the bad iron status. Like they have low level of serum ferritin, low level of serum iron, low level of the IBC, and low level of percentage of TSAT. And we need to prevent iron deficient erythropoiesis. So if we give the patient sufficient iron, we can give the ESA to the patient, and the patient body can produce red blood cell really well. So we want to achieve and maintain target hemoglobin levels for our CKD patient. So I'm going to talk a little bit about iron supplementation, because as I told you, it's the first step apart from the other correctable cause or other additional factors that I told you that we need to find if the patient had other correctable cause or not. And the iron deficiency is the event that we have a lot in our patients. So that's why I need to talk a bit more about iron supplementation, because it's really important, and you can see this iron deficiency in CKD patient a lot more in clinical practice, okay? So iron supplementation, we divide that iron supplementation into oral iron supplementation and parenteral oral supplementation. So previously I mentioned about iron status test, right? For the laboratory test of the patient. So the iron status test consists of serum iron, the IBC, and serum ferritin. And I told you that we can calculate the percentage of T saturation. So the percentage of TSAT is serum iron divided by the IBC and multiplied by 100. So the result is called as percent. So we need the percentage of TSAT over 30%, okay? Over 30%. And we need serum ferritin more than 500 nanogram per milliliter. So we should start iron therapy in our patient if the patient has percent TSAT less than 30% and has serum ferritin less than 500 nanogram per milliliter. So for the patient with CKD and they are not on dialysis. So CKD ND means CKD non-dialysis. So the patient with CKD on stage 3, stage 4, and stage 5 without dialysis, or the peritoneal dialysis patient. So I show you the picture of peritoneal dialysis patient, the patient with stage 5 that need renal replacement therapy. So this group of patient is better to give the patient with oral iron therapy, okay? Because it's very easy, because most of the patients in this group, CKD ND or PD patient, they stay at home. So peritoneal dialysis, the patient can manage by themselves, or the caregiver can help them. So they stay at home. They don't need to go to the hospital frequently. They go to the hospital like every 2 months, 3 months by the doctor visit by the appointment. So that's why oral iron therapy is suitable, is appropriate for the patient, and easy to, like administration for the patient. But for the patient with CKD and depend on the hemodialysis. So I show you the picture of the patient with hemodialysis, right? The patient with hemodialysis, they need to go to the hospital or the dialysis center every 2 to 3 days. So some patient has like twice a week hemodialysis session, or twice a week, like 3 times a week hemodialysis session. They need to go to the hospital, and they need to have that blood from the body. So to wash out by the machine, the dialysis machine. So that means the nurse need to use the needle and pull the blood from the patient body into the hemodialysis circuit out of the body. So as it has the risk that the patient lost iron and lost blood during the dialysis session. So that why if we give oral iron therapy to this type of patient, it's not sufficient, because oral iron therapy is poor bioavailability. It's just like around 20% bioavailability for oral iron. So this group of patient, we need to give them IV iron therapy. So it's better for the patient with hemodialysis. So anyway, so the round of iron supplementation is depend on severity of iron deficiency. So if the patient who are non-dialysis dependent, like CKD patient, and patient with peritoneal dialysis, with severe iron deficiency, like percentage that is really low, like under 10%, you can give IV therapy to this type of patient. So it depends on the round of iron supplementation, is depend on the severity of iron deficiency. We need to, evaluate this issue. And it depends on the response to require oral iron therapy. If the patient get oral iron therapy and it's not sufficient to, to pull up the level of the percentage saturation or serum ferritin, we can give IV iron therapy to the patient. Or the side effects with prior oral or IV iron therapy. Some patients cannot tolerate the side effect from oral or IV iron therapy. So we can, change the route of administration. And the patient adherence. And we know that oral medication, we need the patient adherence, right? If we give the medication to the patient and the patient don't want to eat, don't want to take the medication, it's no use. We cannot treat them because they don't want to take the medication. So the patient adherence is really important in the treatment. Every treatment, patient adherence is very important. But for the hemodialysis patient, the nurse can administer the IV iron to the patient. So it's no problem about the patient adherence. If the patient, they are on hemodialysis and go to dialysis center and the nurse inject IV iron therapy for them. But if the patient has oral iron therapy, we need patient adherence. So this is very important. So the pharmacist should, like evaluate patient adherence. And the last one is the cost. Some patient cannot, like afford the cost of IV iron therapy. So it a little bit, I think I would say like it's a little bit expensive, more expensive than oral iron supplementation. So for oral iron supplementation, we should administer at a daily dose of at least 200 milligram of elemental iron for adults. So in Thailand, I think that is the same in Indonesia, I think. So we use ferrous sulfate and ferrous fumarate. So when we think about the dose of oral iron supplementation, we think about elemental iron. So ferrous sulfate is 300 milligram. It has elemental iron just only 20%. Okay, so infrared fumarate 200 milligram has elemental iron just only 23%. I'm sorry, 33%. So that means for fumarate 200 milligram, they have elemental iron just only 66 milligram. So it is very important that you need to calculate the elemental iron, the milligram of elemental iron to see the, like the real dose that your patient receive. So it should be like 200 milligram of elemental iron for adults per day. So for oral iron supplementation, the benefit, so the pros of oral iron supplementation are more convenient for patients who do not have regular IV access. Like I said to you that the patient without dialysis access and the patient with peritoneal dialysis, they don't have IV access. But the patient with hemodialysis, they have IV access. It is easier to give the IV form. But with the patient with non-dialysis and peritoneal dialysis, oral iron supplementation is better than IV. So it includes patients with stage 3 and 4 CKD and those who are receiving peritoneal dialysis, like I mentioned before. But the limitation of oral iron supplementation is poor absorption. Like I told you, like the bioavailability is just 20%. And it's often inadequate to achieve goal iron index. So, and it needs patient adherence or patient compliance. So for parenteral iron supplementation, I mentioned that this is better for the patient with hemodialysis, right? So in patients with ESRD, GI absorption of iron is often inadequate to meet the increase in iron demand from ESA therapy and chronic blood loss in hemodialysis population, because every session that the patient got the dialysis, you're gonna lose some amount of blood during the process. So oral iron therapy is not sufficient for this patient. So in Thailand, for parenteral iron, most of parenteral iron form that we use is iron sucrose. So we give it to the patient as the intravenous IV, intravenous iron sucrose. So I think that we don't use iron dextran because iron dextran is the molecule of iron dextran quite big, and it can induce like anaphylaxis to the patient. So the iron sucrose molecule is a lot smaller. So the anaphylaxis is rare in iron sucrose. So nowadays we have like low molecular weight iron dextran, I think. And we also use like ferric gluconate for IV iron therapy. So most of the case we use iron sucrose. So we give parenteral iron to the patient to improve their responsiveness to ESA therapy and reduce the dose required to achieve and maintain the target hemoglobin in hemodialysis patients. Like I told you, IV iron is appropriate for hemodialysis patient. Okay, so before we go to ESA therapy, I want to conclude about the iron supplementation that in our patient, like CKD patient, there's a chance, there's a risk that the patient will have iron deficiency because this patient may, like lose their appetite. Some patient has anorexia, uremia, that the patient eats less more. So iron is crucial for red blood cell production. So that's why we need to investigate the laboratory for iron status test. You guys remember how we can calculate the percentage of T saturation, right? And which of iron status test we need to check for the patient. If the patient has percentage of T saturation less than 30% or serum ferritin less than 500 nanogram per milliliter, we need to start iron therapy, oral iron therapy for CKD ND patient or PD patient. And IV iron therapy is suitable for CKD patient with hemodialysis. So when the patient has sufficient iron storage in the body, we can start ESA therapy for the patient. As I told you before, that in CKD patient, endogenous EPO is reduced, right? The production of endogenous erythropoietin is reduced because the renal has their pathology, like it's shut down, it's reduced function, so it cannot produce erythropoietin that's sufficient for the body. So we need to give the patient exogenous erythropoietin like we inject exogenous erythropoietin to the patient. So endogenous erythropoietin or EPO is the glycoprotein hormone. So the endogenous EPO in our body is the glycoprotein hormone consists of 165 amino acids. So the main sign of EPO synthesis is the peritubular fibroblast in the renal cortex that I told you before, like erythropoietin producing cell. So the hormone EPO maintain red blood cell mass by promoting the survival, proliferation, and differentiation of erythrocytic progenitors. So in patient with CKD, is reduced endogenous EPO production. So we need to give the patient exogenous erythropoietin. So let's talk about the exogenous erythropoietin. So nowadays, the exogenous erythropoietin is a biological product. So the exogenous erythropoietin is produced by cell culture using genetic engineering that we call recombinant human DNA technology. So this technology is take like human erythropoietin gene that can produce erythropoietin. So cloning into the DNA vector. So the DNA that clone with human EPO gene gonna have the expression vector and this vector is transferred into mammalian host cell. So the mammalian host cell that we use is Chinese hamster ovary cell. So the vector is transferred into the host cell, and that host cell can produce recombinant erythropoietin, okay? Recombinant human erythropoietin because we use the human EPO gene to produce the EPO. And this EPO is exogenous EPO that we gonna inject for our patients to give the patient higher level of erythropoietin in the body and can produce red blood cell. So for exogenous erythropoietin, we have the first generation and the second generation. As I told you that nowadays we have so many kinds of exogenous erythropoietin. So we call it like ESA, erythropoietin stimulating agent. So the first generation ESA, I think you guys are familiar with these two agents. Like the one is EPO alpha, and the second one is epoetin beta. Okay, so epoetin alpha and epoetin beta, we use it a lot in our patient. It's like the, like the first line ESA for the patient. So this is the innovator Chinese hamster over cell-derived epoetins. So we use the recombinant human epoetin technology. And in Thailand, we also have epoetin theta. So, but we don't use it a lot. We use alpha and beta a lot more. But we also have epoetin theta. So epoetin delta, epoetin theta, epoetin theta, and omega, they're used a lot in European countries. But in America, we use alpha and beta a lot more. For the second generation ESA, I think you guys may be familiar with these two agents too. One is Daraporn alpha, is developed from epoetin alpha, but they use like big molecule to combine with epoetin alpha to make it bigger and stay in the body longer. So the patient don't need to be administered or to be injected by EPO twice every week. So Daraporn alpha can inject to the patient like once a week or one every 2 weeks, like that. So the second generation ESA, another one is methoxy polyethylene glycol epoetin beta, or we call it continuous erythropoietin receptor activator, or SERA, is the biggest molecule of the ESA. So the SERA is developed from epoetin beta. See, this is the molecule of epoetin beta. But with SERA, they use the epoetin beta molecule and combine or attach with the methoxy polyethylene glycol polymer chain to make it bigger, to make the molecule bigger, and can stay longer in the patient body. So SERA, the patient don't need to inject SERA frequently, like it can use like once every 2 weeks or once every 4 weeks, like once a month. So to make it clearer, I show you the graph, compare the half-life between the first generation and second generation ESA. As you see that the first generation ESA that we use a lot are epoetin alpha and epoetin beta. So these two agents is quite, quite similar with their mean half-life. So epoetin alpha and epoetin beta is interchangeable, because it's quite similar in half-life and, effectiveness, clinical outcomes, It's not different. And for Daraporn alpha, the half-life is longer. As I told you, it's developed from Daraporn alpha. So Daraporn alpha is the molecule is bigger, so it can stay longer in the body of the patient. So the half-life is longer than Daraporn beta and Daraporn alpha. For Sera, it's the biggest molecule of ESA, so it can stay longer. Half-life is about like 120, more than 120 hours. And another issue that you see that for the patient who has IV exogenous erythropoietin injection, the half-life of IV administration is shorter than subcutaneous administration. So that's why for the patient with peritoneal dialysis or the patient who are not on dialysis, we give exogenous erythropoietin to the patient as the subcutaneous injection. But with the patient with IV access for hemodialysis, we give IV administration to the patient because it's convenient, it's easier for the nurse to administer to the patient. Anyway, as you see that we need to use a more amount of erythropoietin in the patient who got IV because the half-life is shorter than subcutaneous. Okay, and for erythropoietin theta, that is the new type of erythropoietin in Thailand. So erythropoietin theta efficacy and the like the property is not different from erythropoietin beta. So this is the dose of ESA. So as you see that erythropoietin alpha, erythropoietin beta, and erythropoietin theta is quite the same. So when will we give erythropoietin to the patient? So in CKD ND patient, that means in the patient with CKD who are non-dialysis patient, who are not dependent on dialysis, you can start ESA therapy or give the EPO to the patient if the patient has hemoglobin level less than 10 gram per deciliter. But for the patient with CKD stage 5 with dialysis, the 5D is referred to stage 5 with dialysis. So you can start ESA therapy for the patient if the patient has hemoglobin lower than 9 to 10 gram per deciliter. For me, for the easy remember, I just remember just 10. So if the patient has hemoglobin level less than 10 gram per deciliter, we can start ESA therapy. But we need to evaluate the iron status too, right? If the patient has iron deficiency, we give iron supplementation to the patient. And if the patient has like sufficient iron storage, we give erythropoietin to the patient. And the rate of increase in hemoglobin level that we need in our patient is at least 1 gram per deciliter per month. So it should be like 1 to 2 gram per deciliter per month. And hemoglobin target that we need is 10 to 11.5 gram per deciliter. Anyway, if the patient has hemoglobin over 11.5 gram per deciliter, it should not
Itu bahasa
leave the
Thailand.
patient. So we should not leave the patient to have hemoglobin level over than 13 gram per deciliter because it can cause stroke. It can increase risk of stroke or thrombosis to the patient. For the new guideline in 2025, the hemoglobin target gonna concentrate on like not more than 11.5 gram per deciliter. So by the study, if the patient has hemoglobin concentration more than 11.5 gram per deciliter, the patient tend to have the complication like stroke or thrombosis or cardiovascular disease. So for the adverse reaction of ESA that we need to aware in our patient who have ESA therapy is one is increase in blood pressure. So the patient gonna have like hypertension when they have ESA administration because ESA has the properties of vasoconstriction. So ESA is a vasoconstrictor. So when the nurse inject ESA to the patient gonna have blood pressure rising. So that's why it's very important to talk with the team or to like notify the nurse that before give the ESA injection to the patient, the nurse need to measure the patient blood pressure. If the patient has systolic blood pressure over than 180 or the diastolic blood pressure over than 110, they shouldn't give the ESA injection to the patient. So actually, it's not the like the exact number of systolic blood pressure or the diastolic blood pressure, but we we follow by the blood pressure value for the urgent hypertension or urgency hypertension or emergency hypertension. And for another adverse reaction of ESA is can increase risk of cardiovascular events, like I mentioned before, like heart attack, heart failure, blood clots, like thrombosis, stroke, and death. So that's why we need to avoid the like hemoglobin concentration over than 13. Or we need to keep it between 10 to 11.5 gram per deciliter for hemoglobin concentration. And in the patient who has hemodialysis, they're going to have the problem with hemodialysis access thrombosis. And some patients going to have seizure. And this important adverse reaction is pure red cell aplasia or PRCA. So PRCA occurs from the generation of antibodies against recombinant human erythropoietin, resulting in the absence of red cell precursors in the bone marrow. So the bone marrow fails to produce mature red blood cells, leading to severe anemia. That means if the patient was injected with ESA, and the patient has PRCA, that means the patient has worsening anemia. Even you increase the dose of ESA, that anemia got worsening. If you increase the dose of ESA and the anemia get worsening, and you assess there's no any other additional cause to make the anemia worsening, you should think about PRCA. So anyway, the incidence of PRCA was associated with subcutaneous administration. It's less than IV administration, it's less in IV administration. Most of the case, PRCA was associated with subcutaneous administration of ibuprofen alpha, okay? So the risk is subcutaneous administration and ibuprofen alpha use. Moreover, we should avoid brand substitution or multiple switches to reduce risk of PRCA because So in Thailand nowadays, we have both innovative epoetin, innovative recombinant human epoetin, and biosimilar recombinant human epoetin. So the biosimilar recombinant human epoetin is like the generic drug. So we have innovative drug and generic drug, right? Generic drug is the drug that copies the innovative when their patent is expired. So the generic drug is tends to more affordable for the patient. So the generic EPO for recombinant human epoetin, we call it biosimilar EPO. So there's so many brands of biosimilar EPO, and the EPO is biological product, right? So biological product is large molecules and complex structure. So it's produced by genetically modified living cells in a complex biotechnology processes. So different manufacturing processes affect with the efficacy, safety of the treatment, and the immunogenicity of patients. So it's very, like difficult to control the quality of biological product. I mean, it's more difficult than chemical product. So that's why we need to avoid EPO brand substitution or multiple switches to reduce risks of immune stimulation and pure cell aplasia. Okay. So in Thailand, I talk about the situation in my country that we have our own Thai version of clinical practice guideline for anemia in CKD. So this Thai guideline launched in 2021 by the Nephrology Society of Thailand. So it's quite different. So it had the same part, the similar part with KDIGO guideline. But for Thai guideline, we include the study in our own population, our Thai population. And we follow the situation and the, like the scheme, healthcare scheme of Thailand. So that's why it's suitable to use with the Thai people. So like in Indonesia, I think you may have like your own clinical practice guideline that's suitable with your people and suitable with the like the environment of healthcare in Indonesia, like the healthcare system, healthcare scheme for the people in your country. So like in Thailand, we use both KDIGO guideline for to be our patient care guideline, and we use Thai guideline also. So I like this, I like this picture because it's very easy to use. It's conclude everything in one, like one picture to adjust the medication to treat the anemia in CKD patient. So we start at the assessment of hemoglobin level. We need to assess and evaluate the hemoglobin level of our patient. So if our patient has hemoglobin lower than 10 grams per deciliter, we're going to increase EPO dose, exogenous EPO dose, 15 to 30%. But if our patient has hemoglobin level within goal between 10 to 11.5 grams per deciliter, we assess iron status of the patient. Please don't forget about assessment of iron status. We assess of iron status and we concentrate on the ferritin level, serum ferritin level, and percentage of T saturation level. So, and we manage by this scheme. So if our patient has ferritin over than 800 nanogram per milliliter or percentage of T saturation over than 40%, we stop IV iron therapy. But if the patient has like T-stat within goal, we can, continue the maintenance dose of iron therapy as stated in the picture. So if our patient has higher hemoglobin level, higher than 11.5 gram per deciliter, so we will manage by decrease the dose of EPO. So we decrease the dose down to 15 to 30% of the dose. But if the hemoglobin level over than 13 gram per deciliter, we need to stop EPO for 1 or 2 weeks. And then start with the dose decreased by 50% of the previous dose of EPO. Okay. This is just the example how we in Thailand manage anemia of CKD in 2021, and we use it until now. So another treatment for anemia of CKD is blood transfusion. So blood transfusion is modulate immune system. So we need to be aware of the relevant adverse effects like fever, allergic reaction, like itching, rash, or heat. And we don't use blood transfusion for long-term therapy in CKD patient with anemia because iron overload. We need to be aware of iron overload. And we need to aware of sensitization to HLA antigens before the patient who are the kidney transplantation candidate. So in patients with anemia and CKD who are eligible for kidney transplantation, we're gonna avoid red blood cell transfusion whenever possible to reduce the risk of allosensitization that can lead to graft rejection after the patient have kidney transplantation. So this is very important. So we don't use blood transfusion if the patient don't need it, okay? So anyway, the blood transfusion may outweigh its harm in patients whom symptomatic anemia. If the patient has symptomatic anemia, like the patient who has hemoglobin lower than 7 or 6 can have symptoms, so we can, consider blood transfusion for the patient. Or the patient who got like ESA therapy, but is ineffective, like the patient with hemoglobinopathies, the patient with bone marrow failure, or the patient with ESA resistance. And the patient who got ESA therapy but is harmful to them, like the patient with previous or current malignancy, because high dose ESA can induce malignancy. And the patient with previous stroke. But I told you that if they have a large, like big amount of ESA and can cause hemoglobin concentration over than 13, it can be the risk of stroke in that patient. So the patient with unstable condition, you can consider to give blood transfusion, like the patient with acute hemorrhage, the patient with unstable coronary artery disease, or the patient who need rapid preoperative hemoglobin correction. So, okay, this is the important part of today. Another important part. So we know about the basic, basic knowledge of anemia in CKD and the current treatment of CKD. So this year, KDIGO it's gonna launch, I think maybe soon. They will launch KDIGO Clinical Practice Guideline for Anemia in Chronic Kidney Disease 2025. So the latest issue is in 2012, right? So it's time to launch a new one this year. So previously in November 2024, KDIGO launched the guideline, the draft of the guideline for public hearing. So please note that this is a draft document only. So the things that I'm gonna talk the things I'm gonna talk is just solely, like the draft document. So maybe the content of this guideline will change based on the feedback that they receive from the experts. So this is not the final version, okay? But I'm gonna talk to you to see what will happen in the next near future, okay? So we need to continue, like follow the launch of this newest guideline. So anyway, we need to wait for the complete issue of KDIGO 2025 clinical practice guideline for anemia in CKD patient. But I'm gonna talk a little bit about what's gonna be changed in this version of the guideline. So the diagnosis and evaluation of iron deficiency and anemia in CKD is just a little bit changed, I think. The criteria, the number, the amounts is quite the same, but it's maybe a little bit changed. And the use of iron to treat iron deficiency and anemia in CKD is quite the same. But so the things that change a lot in 2025 is we have the new agents. The new agents that can use instead of ESA. So the ESA form that we have is just only IV or subcutaneous, right? We administer ESA by subcutaneous injection or intravenous injection to the patient. But we have new agents that is oral medication. So the patient don't need to get like the injection to have the medication that can increase red blood cell production. So the new agent we call HIF stabilizer. So we're gonna talk a lot more. HIF stabilizer and other agents that are used to treat anemia in CKD. So, but the biggest issue is HIF stabilizer. And the red cell transfusion to treat anemia in CKD is quite the same. So I want you to know about the HIF stabilizer. So I will introduce the HIF stabilizer to you. So in our body, they have a protein called HIF. HIF1 and HIF2. HIF is hypoxia inducible factor. Okay, HIF is hypoxia inducible factor. So what HIF helps with the body? The first one, HIF help to inhibit hepcidin. So hepcidin gonna reduce and it can increase in absorption of iron from intestine and mobilization of macrophage iron. Okay, and HIF can stimulate DMT1. DMT1 can like increase absorption of iron from intestine and mobilization of macrophage iron. And HIF can help with iron transport also. So it helps in iron transport to bone marrow cell. So the first one, HIF help iron usage, right, to produce red blood cell. Moreover, it helps with EPO gene transcription. It increases EPO gene transcription. So that's why it can help to increase EPO activity. So the function of HIF is, the conclusion of function of HIF is increase erythropoiesis or increase the production of red blood cell by working with iron and working with EPO gene transcription. But HIF can work in the environment of hypoxia. But in the environment with oxygen, they're gonna have HIF Ph.D, like hypoxia inducible factor proryl hydroxylate domain that inhibit HIF. So the hip stabilizer or hypoxia-inducible factor prolyl hydroxylase inhibitor gonna inhibit hip Ph.D. So it can cause hip work better. Okay, so it help with the work of hip function to increase erythropoiesis. So the first hip stabilizer that launched to the market is roxadustat. I'm not sure any one of you heard about roxadustat before, but roxadustat is the first hip stabilizer that launched into the market and approved in China. So there's so many studies about roxadustat efficacy and safety. So one of the study conducted in 2021 is randomized clinical trial in like around 1,000 patients. In the CKD patient depend on dialysis. So this study compares 70 milligram or 100 milligram twice a week, 3 times a week. So roxadustat the patient don't need to take every day. Take just only 3 times a week. So this Himalaya study compare roxadustat 3 times a week with parenteral epoetin alpha. And the outcome measure its mean change from baseline in hemoglobin over week 28 to 52 and hemoglobin response during the first 24 weeks without rescue therapy. So this study result found that roxadustat was efficacious in correcting and maintaining hemoglobin levels compared with epoetin alpha. So roxadustat had an acceptable safety profile too. Okay, and another one that studied since 2016 is daprodustat. So daprodustat was studied both in dialysis dependent patients and non-dialysis dependent or peritoneal dialysis dependent patients and non-dialysis dependent patients. So as you see that daprodustat start the study in dialysis dependent patient first, and then non-dialysis dependent or peritoneal dialysis dependent patient, and then non-dialysis dependent patient. So they study until 2022, and daprodustat was approved in Japan. So as you see that hip stabilizer was studied in many groups of CKD patients, both non-dialysis dependent CKD patient and dialysis dependent CKD patient, in the issue of the correction or maintenance of hemoglobin level in this group of patients. And they measure iron parameters like ferritin, TIBC, transferrin, hepcidin also. And as I told you that hip stabilizer help with the iron function, so that's why they study about the iron parameters. And they study about IV iron use, need for blood transfusion, serum cholesterol, and safety in this group of patients. So it's conclude that hip stabilizer demonstrate efficacy in the treatment of anemia of CKD. And preliminary data suggest that hip stabilizer have effects beyond erythropoiesis and iron metabolism, impacting cardiovascular safety. Anyway, in many studies, it said that there is some cardiovascular side effect from hip stabilizer. So long-term safety needs to be established in extended trials. So we need to study more about the safety of the medication in hip stabilizer group, and also post-marketing analysis. So as you see that we have so many hip stabilizers. Like the first one is roxadustat, right? And we have daprodustat, we have vadadustat, we have molidustat. And the hip stabilizer that developing during 2021 to 2022 are desidustat and inarodustat. So from these studies, they found that hip stabilizer still have the cardiovascular events effect. And another adverse drug reaction is cancer development. So that's why in KDIGO 2025 guideline, they warning about observing the adverse reaction and concern to use in the patient who has malignancy. Okay, so how about the status of hip stabilizer in 2025? So this is from the draft guideline of KDIGO, but it's the status of hip stabilizer, the sixth item of hip stabilizer in 2025. So all 6 hip stabilizer are already approved since 2024. So for that produce that it's approved in Japan and the US. So that produce that is only approved for dialysis-dependent CKD patients only in the US. And in Japan, they approve for both CKD receiving and not receiving dialysis. So that's why in the US, they use the produce that to treat renal anemia only for the patient who has dialysis only, like hemodialysis, peritoneal dialysis. But in Japan, the CKD patient who are not on dialysis, they can use that produce that. So we need to, as I told you that this group of medication is the oral medication. So the patient don't need to inject like the EPO. It's oral, so the patient can take the medication. So we need to concern about the drug interaction. So that produce that primarily metabolized by CYP2C8. Okay, and the second one, desidustat, is approved in India, and inarodustat. Inarodustat is metabolized by CYP2C8, 2C9, and 3A4. So this is we need to concern because CYP3A4 inducers and inhibitors, we have a lot. 3A4 inducer inhibitors, right? It can cause like drug interaction. Also, CYP2C9 is a lot. So inarodustat approved in China, Japan, and South Korea. And molidustat approved in Japan. And for the first one, see, the first one, roxadustat, is the first agent in the group of hip stabilizer that launched in the market. The approval of marketing in 2024 is a lot. Like the first country that approved roxadustat is China. Then Chile, Egypt, EU, like Japan, UK, South Korea, Turkey, UAE, Mexico, like so many countries. And roxadustat is the inhibitor of CYP2C8. The last one is vadadustat. Vadadustat is the inhibitor of CYP2C8 and the inducer of CYP2B6. So vadadustat was approved in Australia, the EU, Japan, South Korea, Taiwan, and the US. So vadadustat is only approved for dialysis-dependent CKD only in Australia, EU, Korea, Taiwan, and the US. In Japan, you can use vadadustat, both CKD receiving or not receiving dialysis. So, okay, I'll go to the conclusion. So we still have sometimes to discuss and for the question. So the concept of anemia of CKD management is the pathophysiology of CKD anemia is multifactorial. As I told you before, it's multifactorial. It can cause from any additional other cause that can cause worsening anemia. So we need to require a holistic approach. So that we need to evaluate of additional factors of anemia to address and manage all correctable causes of anemia prior to initiation of ESA injection. And for the patient who has iron deficiency, we need to study iron therapy or iron supplementation. And then if the patient has sufficient iron status, you can use erythropoietin or ESA. So even in the 2025, the year of 2025, ESA will still be the first line therapy. Okay, so ESA is the first line therapy for anemia treatment in patients with CKD. This is not changed. It still be the first line, but we have the additional choice. We have the additional choice in 2025, but it's still not worldwide. It just have in some countries. So hip stabilizer are new drugs for increasing erythropoietin. So the available data until now suggests that there are efficacious and safe alternatives to ESA for the treatment of anemia in both like non-dialysis dependent or dialysis dependent CKD patients. Anyway, as it the newer agent, so it's not a large number of patients that have a chance to use this medication. So post-marketing surveillance should be continued to detect the adverse reaction, to evaluate the safety of the medication. And sure, we cannot work alone. As I told you, we cannot work alone. We need to work with the team. So multidisciplinary care team is very important in taking care of CKD patients. So the care should be provided through collaboration with patients. So we need to do like the patient-centered process. And we need to have the team, the healthcare team. So for me, I work with the healthcare team at my practicing site of the Faculty of Pharmacy, Silpakorn University. We engage with the teaching hospital in Bangkok. I go to the hospital and take my student with me to do the team round, to study with the patients, and I accept the consultation from the team, from the doctor, from the nephrologist, from the nurse, and we have the roundtable case discussion every month, at least every month, and we have if we have another additional case, we also consult together. So if we work with the team, we can taking care of the patient really well. So the medication reconciliation is really important. So this is my student. I think they are the 5th year student, the P5. So they go to the practice side, the main practice side of our faculty, and they do the medication reconciliation together, talking with the patient. Okay. So I think maybe the thing that I provide you will be benefit for you in, like the update in data information or the update clinical practice for you to taking care of your patient. Thank you very much. So if you guys have the issue to discuss or have any question, you are very welcome.
Okay, thank you so
Thank
much,
you.
Dr. Daisy. It's really comprehensive what you delivered, and almost you delivered 90 minutes. So it's very interesting topic as well. Is that I think you expert on this field. So, Dr. Desio, I think we have two questions from our audience here. I think so. I will read it for the questions. Okay, wait minutes. Yeah. So this is the questions from one of our audience, Dr. Desi. I think he asking us about the genomic behind of the therapy of the anemia in CKD. I think you already delivered, right? You already explained in some of the medications they haven't some of the genes involved in the metabolize of the medicine. So from Mr. Gusti, he said that I would like to ask the questions regarding CKD, anemia, and associated with the genetics. Currently, genomic is the trending field in the research for precision medicines, these treatments. So in this field, in this regard, is there a relationship between specific gene mutations and the increased risk of anemia or high risk of anemia in patients with the CKD? So this is
So until now, there's a limited information about the genetic that relate with the anemia in CKD. So I would say that until now that there's no the medication that need to include with the genetic polymorphism or something like that with the anemia in CKD.
Well, I
Okay,
think
but
that's interesting topic, right? So if there
yes,
is
it's very interesting. Maybe we can study more about the genetic aspect of the medication that we can use in anemia or the gene that can cause the worsening anemia in this group of patients. But until now, I don't see any things about the genetic things related with anemia of CKD.
So I think yeah. This is actually this is the challenging. So even that there is no informations, but we can do start for find out which the polymorphisms or with the specific genes that associated with high risk for anemia, right? So I think later on
Yes.
we can discuss about this.
Yes, especially with the hip stabilizer, so it's gonna, I think, in my opinion, I think it's gonna launch with the new guideline of KDIGO, I think. Because all 6 medication in this group have already approved in some countries. So it's very interesting to study more about the hip stabilizer. But I think in Thailand, in Southeast Asia, it's limited access of our patient to medication. I think it's maybe expensive, more expensive, a lot more expensive than ESA. So we just to wait and see because we don't have any hip stabilizer in Thailand until now. But I think maybe in the future, maybe we're gonna have a chance to use it with our patient because I think there's gonna have the attempt to bring some medication in this group into each country in Southeast Asia, I think.
Okay, so yeah, this is interesting as even that the challenges, but this is the opportunity for us to find out the specific genes, right? So
Yes.
this is the opportunity for especially for us, Dr. Daisy, to write the paper writings for this field. So there is the another questions I think from Dr. Ipa. Yes, this is the question. This second question, she asking about. Oh, wait minutes. Okay, from Dr. Ipa. Dr. Ipa is a lecturer in our faculty. Thank you for interesting presentations, Professor Daisy. So as you said that oral iron supplement has poor absorptions. So how to improve or solve these outcomes? Since the pharmacy services, we want to answer the efficacy of the therapy. And in the anemia patients with CKD, when do they need both in iron supplements and hypotherapy? You
Okay,
got it.
that's very good question. Really, really good question. So, as I am the clinician, I would say that I am the clinical pharmacist. So I would answer in the aspect of the clinical aspect. Okay, the clinical
English suruh baca.
okay. So I would answer in the clinical aspect. So that to increase the absorption of iron supplement, we tell our patient to take the iron supplement, I mean oral iron supplement, at least 30 minutes before meals, to increase the absorption. But unfortunately, the iron supplementation that has a side effect about GI irritation, right? Yeah. So some patient has nausea, vomiting, or GI discomfort. So if the patient has GI discomfort, I need to accept that the patient need to take it after meal. So the absorption will be decreased. But we have the study that take 3 tablets of iron supplement, oral iron supplement. I think it's for fumarate, 3 tablets before bedtime. Like before bedtime, it increase the absorption and it can increase the iron status. So this is like the how to solve the problem in the clinical way. But for the formulation, I think maybe we can create the formulation that can have the better absorption. So that the thing that we know that we combine iron with vitamin like vitamin B, vitamin C to improve the absorption.
So, but there is no specific formula from the industry right now, right?
Yeah, we have the combination, like we have FBC, we have for us combination with vitamin B with vitamin C is coming to one pill. So it can increase the absorption of the ferrous to the patient. And most of the time I use the way that I told the patient that can you try taking the ferrous tablet before meal, like 30 minutes before meal, if you have no symptom of side effect. So you go on, you take before meal. But if you have the side effect, you can take like after meal. So my friends, they used to use like 3 tablets of fumarate at bedtime. So the patient has the good result, but some patient has like GI irritation. So like because it high dose, right? More absorption, but high GI irritation. But some patient can tolerate that. So the big dose at bedtime is another way to improve the absorption.
Okay, thank you so much, Dr. Leslie. We got it, the point that you delivered. So, the medications for CKD, for anemia in patient with the CKD on your country is covered by all the insurance or all the insurance of Thailand government.
So yes. So but just only so the government they help just only for the epoetin alpha.
Oh, I see. So not
Not
all.
for Darby-Point alpha, not for Sera.
Oh, I
So
see.
because it's more expensive, if the patient want the second generation ESA, they need to co-pay. They need to pay by themselves. But if EPO alpha, the patient can have the government gonna support the price of the medication.
Oh, I see. Okay, got it. So even I think even in our countries, the national insurance still have big problems. Yeah,
And another question,
not all the
another question from Dr. Ifa is when we give like iron therapy together with EPO therapy, right?
Yeah, oh, yeah. The
So
Yes, two
This
questions.
is a
That's
very
right.
good question. So this is very good question. So actually, if your patient has the sufficient iron therapy, iron status, you can give erythropoietin together with iron for the maintenance dose. So we give iron for the maintenance dose. Let me show. I want to share the picture that is our Thai guideline. Okay, I'll find that picture. Okay, this one. Okay, let me share the picture. Oops, sorry. Okay, this one. As you see, if the patient has sufficient iron status, so you can give the iron therapy. If the patient is depend on dialysis or have hemodialysis, you can give IV iron to the patient together with erythropoietin. Okay, so the importance of sufficient iron status in each patient is very important because if you give the patient sufficient iron therapy, it will decrease the dose of EPO. It means it can increase EPO responsiveness to for the patient. So that means we don't need to use the big dose of EPO, right? So the big dose of EPO can cause malignancy in long term. So it can cause angiogenesis and it can cause malignancy. So that's why we avoid high dose EPO. That's why I told you that you need to correct the iron status of the patient first, okay, by giving the patient iron supplementation. If your patient has sufficient iron supplementation, you can give the maintenance dose and you can give EPO to the patient. So if you give sufficient iron therapy to the patient, you can decrease the dose of EPO. You're going to use less EPO. So it can, like minimize the risks of high dose EPO use and risks of malignancy.
Okay, so yeah. Okay, so we
Does
got
this answer your question, Dr. Ifa? I'm not sure. So you can add a lot more
sudah
if it's
menjawab.
not.
Yes, Professor. Thank you. It was very nice answer.
Thank you.
Yeah, thank you, Bu Ipa, for the patience. So, Dr. Desi, on your country, that for the blood transfusion, so the threshold of hemoglobin is how many? The threshold for on your
Oh, the
country?
threshold. Like I mentioned that most of the case we gonna use medication therapy first, like the iron supplementation and erythropoietin first. We try to avoid blood transfusion. If the patient don't, need the blood transfusion, really need the blood transfusion, because it can cause, it can, like activate the immunogenicity of the patient. And if they're gonna go to have the kidney transplantation in the future, it can cause a rejection for the patient. But if the patient has anemia or worsening anemia with symptomatic anemia, so most of the case, symptomatic anemia will come from the patient who has hemoglobin lower than 7 grams per deciliter. So it not have the exact number or exact cutoff of the hemoglobin value, but we concern the patient symptom primarily. Yes. So most of the case it like hemoglobin like 6 to 7, lower than 6 to 7. But in some case, if they have chronic anemia, they can tolerate. Even hemoglobin lower than 5, they can tolerate. They don't have any symptom. So we're gonna concern with the patient symptom first.
I see. Thank you so much, Dr. Daisy, for great explanations and also the presentation. So this is, I think, we got a lot of new insight from your presentation, Dr. Daisy. So, but unfortunately, not all our students can attend this webinar. So I said to my coordinators that I think unfortunately not all students, because this is a lot of new things you already shared to us, especially for the new guideline for 2025. So I think we use two guidelines, right? KDIGO and also the Kadoki, right? So, but in our countries, actually, we use these two kind of the guidelines for the CKD. So thank you
So
very much. Yeah.
it's like in Thailand, right? In Indonesia, you use your national guideline
Yeah,
and
but
Kedoki like that.
yeah, kind of that. Yeah, so
Okay.
we adopted from those two kind of guidelines. Okay, Dr. Daisy. So thank you very much, Dr. Daisy, because of the limited time, but you already shared to us about the new things about the CKD, especially anemia and CKD. So before we end the sessions, do you have any words that you would like to share to us? Short word.
So So like I said before, I feel honored and I'm really happy to meet you all today. So because UAD and SU we have the collaboration, right? We have academic MOU together, and I think this event is really special event that UAD hosts under our MOU. So we can have academic session like this in the future.
Of course.
Yeah, just you just text me and you just tell me what topic you want me to present to you.
Of course.
So it's my pleasure to be here today, and thank you very much. Like we're gonna be the like a good university partners, and we will continue our good friendship, our good academic relationship, right?
So
Thank
now
you
we
very
are
much,
still, yeah,
everybody.
thank you very much. We are still selected our students who would like to join the your programs in this year's 2025, right? So thank you very much, Dr. Daisy, for your sharing it to us, and also for your kindness uh, to give us a new insight for CKD, especially in anemia of CKD. So we are waiting for your presentation, for your next presentation, I think. So thank you very much for good collaborations between UAD and also the Silpakorn University in Thailand. So thank you once again. We
Thank
close
you very much.
the sessions, Dr. Daisy. So
Yeah.
see you next time. Thank you so much.
Yeah. Thank you very much, everybody. See you
Yeah,
next
thank you,
time.
Professor.
Yeah. Bye-bye.